Hi everyone, we're here for part 5, talking about bacterial infections. We're going to try to get through this as soon as possible. I don't know if you're tired of hearing about infectious disease, but I'm getting ready to be done with talking about it. So here we go. So we know that although bacterial infections are less than viral diseases, they allow us to do something about it, such as antibiotics that can decrease the effects of the illness and prevent any complications. We're first going to talk about MRSA, and it's important with community-acquired methicillin-resistant Staph aureus to know what your prevalence of it is in your community. That information will be used to better treat, pneumonia, cellulitis, osteomyelitis, bacteremia, endocarditis, abscesses, necrotizing fasciitis. Some of the clinical signs that you may see is a boil or an abscess without pus that is developed rapidly. You may note that it fails treatment with a beta-lactam agent. You may know that other family members have similar infections. If you have a little one that has skin or soft tissue infections. It's important to know if there's been a history of recurrent small or non-tender maculopapular lesions or multiple lesions. And also certain ethnicities are more prone to these, and those with lower socioeconomic status. And then it's important to know if there's been a history of a hospitalization in the past year, and if the child attends daycare or if they're less than 2 years old. So when we go to care for these lesions, if it's superficial, it can be treated with likely a topical antibiotic. It's important that the patient is aware of follow-up if the lesion is not improving. If there is widespread impetigo, it might require oral or IV antibiotics. Some of these lesions may require an IND and a culture if it's non-draining. If there's been a fluctuant abscess, antibiotics are not needed if it's mild. The drainage itself may solve the issue and allow for the body to kick in. If you have an immunocompromised patient, it's important to refer them to an infectious disease specialist. Testing that you would do would be a gram stain, a culture and sensitivity, and sending for the D test, and this indicates any possible inducible resistance to clindamycin. Warm compresses can also be used to localize pus when needed in a non-fluctuant lesion. So if you have an uncomplicated soft tissue infection without any fluid fluctuation, topical mupirocin 2% is usually sufficient. Moist heat can help promote drainage, and the use of oral antibiotics should be used if you have a suspected MRSA infection with the following circumstances, such as the presence of an abscess or rapidly progressing local infection with signs of cellulitis. There is a good figure in the book, figure 24-6, which is an algorithm for the management of skin and soft tissue infections in the outpatient setting. I encourage you to look at that. And then on table 24-7, there is a section on outpatient treatment options for mild to moderate suspected MRSA. And those both have good information. Next, we're going to talk about cat scratch disease. It's a slow-growing gram-negative bacillus, and it is the most common cause of chronic persistent, meaning greater than 3 weeks, lymphadenopathy in children. And it is seen in 90% of the cases, and it's usually where a cat is involved, but occasionally can be a dog. And it's usually transmitted from a bite or a scratch, or from hands contaminated with flea feces that touch an open lesion or the eye. On your clinical findings, you may see a 3 to 5 millimeter reddened papule that is healed, and then you may have lymphadenopathy for 1 to 4 weeks that could persist up to 1 year. A small percentage of kids may present with a paranod ocular glandular syndrome, which is a painful non-suppurative conjunctivitis, and you may see preauricular lymphadenopathy. And so it's projected that the organism made it to the eyes by rubbing the eyes after handling a cat. Recovery usually happens spontaneously in 2 to 4 months after the onset of the symptoms. In an immunocompromised patient, you might find recurrent fevers, bacteremia, and weight loss. Diagnostic studies include IFA, which is your indirect immunofluorescent assay for serum antibodies, a CBC, and you may see mild leukocytosis, and then a SID rate and a CRP may be elevated early on. Differential diagnosis includes any cause for lymphadenopathy. Management, most cases resolve spontaneously. Antibiotics only if there's a concern for systemic cat scratch disease, and treatment for immunocompromised patients may include oral agents and parenteral gent. Complications may include a systemic illness with high fever, malaise, fatigue, anorexia. There may be enlarged mediastinal nodes causing pleurisy or obstruction of the respiratory system, and you can have splenic and hepatic abscesses. Patient and family education includes washing the cat scratches with soap and water, and if you do have a patient that's immunocompromised, they should avoid cats. So next we're going to talk about Kingella-Kingay infection, and it is an invasive disease seen in children greater than 6 months and less than 4 years. It's not typically seen in infants. We have this organism as part of our normal flora in the pharynx, and it's found in kids greater than 6 months old, and it's a larger percentage than what is seen in adults. It can also be easily transmitted in childcare settings. The onset of the infection may be very gradual, which can result in a delay in the diagnosis. The organism is the most common cause of septic arthritis in children, and needs to be ruled in if the child has a negative skeletal infection. Septic arthritis usually involves the knees, the hips, or the ankles. It's susceptible to many antibiotics, but it is resistant to clindamycin and vanc. Next, we're going to talk about meningococcal disease, and it's caused by many organisms, but we're going to focus on and meningitis here. It's found in the human nasopharynx and is spread from person to person via respiratory secretions, mainly large droplets, or contact with saliva such as kissing. Asymptomatic carriers are the most common source of transmission. You can have epidemic type situations in semi-closed communities such as daycares, schools, and college dormitories, and military barracks. Clinical findings include occult bacteremia. You can have a febrile upper respiratory or GI infection that may resolve without an intervention. You may see meningococcaemia, which is rapid progression over several hours, and the child is going to develop a fever, septic shock. They can have petechia to purpura on the skin, blood pressure will drop. They could go into DIC, adrenal hemorrhage, organ failure, coma, and death can result in approximately 12 hours. With meningococcal meningitis, it's known for the fever, the headache, the stiff neck. Diagnostic studies include a positive culture and gram stain from the CSF, blood or synovial fluids, and a PCR assay is useful if antibiotics are given. Differential diagnoses may include septicemia, viral meningitis, and other diseases causing fever and a rash. Management includes hospitalization and IV antibiotics pending cultures. There are some control measures that are used if someone's been exposed, and these would include individuals in the household, the school, or contacts of the child who develop febrile illness, and they must be evaluated for the disease. And households that have someone that has been exposed have a 500 to 800 times risk factor of contracting the disease than someone in the general community. So control measures may include chemoprophylaxis, meaning giving the medications within 24 hours of exposure, regardless of what their immunization status is. If a child has had close contact with someone 7 days before the onset of symptoms, they are at an increased risk. If there's been airline travel for more than 8 hours while sitting next to an infected person, that would qualify for prophylaxis. So complications can be caused by the inflammation. There can be intravascular hemorrhage, organ necrosis, shock, deformities, seizures, deafness, and hydrocephalus. Next, let's talk about group A strep, and it's a group of microbes that invade the respiratory tract, skin, soft tissues, and blood. It's transmitted through secretions in the upper respiratory tract. Streptococcal pharyngitis is common in the winter and early spring, and it's rare among children less than 3. The incubation period is 2 to 5 days for the pharyngitis and 7 to 10 for skin infection. Clinical findings may include a peritonsillar abscess, cervical lymphadenopathy, and GABHS. You may see scarlet fever. It may be present as an abrupt illness with a sore throat, fever, vomiting, headaches. There may be reddened tonsils with exudate. There may be a strawberry tongue and a sandpaper rash. You can see bacteremia such as meningitis, septic arthritis, and pneumonia. There can be vaginitis with toxic shock syndrome. There can be perianal streptococcal cellulitis, skin infections, rheumatic fever, and necrotizing fasciitis. Antimicrobial therapy is used to decrease risk of complications. There is a disorder called PANDAS, which is your pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, and this is thought to result from production of autoimmune antibodies, and these may include obsessive compulsive disorders, tic disorders, and Tourette syndrome. Next, let's talk about TB, which is the Mycobacterium tuberculosis that is slow growing. It's moderately infectious in most situations. The degree of infectivity depends on the intensity and the length of the exposure to the bacilli. It's primarily spread through droplet contamination from coughing, sneezing, or talking, and these droplets can suspend in the air for hours. TB can either be latent, which the individual is infected but not contagious, or active, and there's signs and symptoms of active disease. Infection is noted when converting from a negative to a positive skin test, or having a positive interferon gamma release assay. Progression to disease is highest in infants and those between 15 and 25 years and an older adult. Clinical findings are going to include primary pulmonary tuberculosis, and look at table 24-4. Take that back, it's table 24-8, that's incorrect. And it talks about characteristics of tuberculosis in children. You can see a low-grade fever, non-productive cough, decreased appetite, weight loss, failure to thrive, night sweats. 25 to 30% will have extrapulmonary symptoms. Some risk factors would be close contact with others with TB, immigrants, clinical signs of TB. If the individual is HIV positive or exposed to HIV or drug use, those that have Hodgkin's disease, lymphoma, diabetes, renal failure, or if you are in a homeless shelter, nursing home, or correctional facility. So we know that the TB skin test is positive if there's a 5 millimeter or greater wheal for those that are in close contact with somebody with TB or have a chest X-ray consistent with active TB or immunocompromised. 10 millimeters or greater if they're under 4 with any high risk, 15 or greater if greater than 4 or without risk, and if there's an onset of induration after 72 hours. Management will be consultation with the TB specialist. It's a reportable disease to your state and local health department, and there are anti-TB drug regimens that help with adherence and include your isoniazid, rifampin, ethambutol, and those are the most common forms. Monitoring is important to make sure there's compliance with the treatment, so it's important to evaluate all individuals being treated, and routine labs are not recommended in complications can be increased pulmonary disease, reactivation of pulmonary TB, miliary disease, lymph node disease, pleural effusions, drug-resistant tuberculosis, etc. I'm going to let you read about this on your own. It's infectious diseases that originate in animals and will move on to a child that presents with fevers. So children presenting with fevers are typically greater than 100.4. You need to be concerned if you have neonates, infants, or children that have fever without a focus or fever of unknown origin. Infants that are less than 3 months, these fevers are usually viral, but they still must be worked up for bacterial diseases. Viruses, we know, have seasonal patterns, so it's important to take that into consideration. You can have bacteremia in 5% of infants less than 3 months, and it may present as an occult infection in young infants and children. So fevers without a focus, birth to 24 months, are at your greatest risk. Having a febrile illness without an obvious etiology. If you look at table 24.9, it gives the most common pathogens. It's important, as always, that we do an extensive history and physical, duration, degree of illness, and the fevers, associated symptoms, exposure, vaccines, their neonatal history, chronic illnesses, current meds. If you look at figure 24.8, there's a diagnostic workup algorithm that will help guide you based on age and what to do next. If you do have a child that has a febrile illness that's less than 36 months that you cannot differentiate, they need to be admitted to the hospital. So a negative low-risk workup results may include WBCs less than 1,500, with bands less than WBC less than 15,000, bands at 1,500, a cath UA that has less than 10 WBCs and is negative for leukocytes and nitrates, fewer than 5 WBCs in stool, a negative chest X-ray if cough is present, cultures that are monitored every 24 hours until the final result, and viral testing. Some differential diagnoses may include upper and lower respiratory diseases, GI diseases, musculoskeletal infections, and bacteremia. Management includes applying the risk criteria, and that is found in the book, and that is used for identifying infants younger than 3 months who have serious bacterial illnesses. We talked about the low risk, I believe, on the previous slide, but be sure and look at the more the specifics of that in the book. And here are the high risk. So a febrile infant less than a month, that's toxic appearing, infants 1 to 3 months with a fever, infants 1 to 3 months with chronic illnesses or unreliable caretakers, infants less than 3 months with a focal sign, infants or children 3 to 36 with a temp greater than 39 degrees Celsius and has a high risk with laboratory results, and any child, a child of any age with fever, petechiae, and who is ill appearing. I'm going to let you read the low risk there. Follow-up for any child that's not hospitalized. They need to be reevaluated in 24 hours. If that falls on the weekend, then they need to have access to the emergency department. There needs to be daily follow-ups on cultures to see what the results show. They need to be seen immediately if cultures are positive. The parent needs to have detailed instructions on symptoms to report if worsening, what to do, who to see for careful follow-up, etc. So fevers of unknown origin, just very quickly, greater than 3 weeks, no etiology despite workup. In children, it's most common. You'll see that with a UTI or pyelonephritis or respiratory illness. In adolescents, the most common is tuberculosis, autoimmune disease, lymphoma, and inflammatory bowel disease. Clinical history, important for symptoms, signs, past medical history of infection, surgery, meds, family history, any family pets, any unusual dietary habits, and pica. On physical exam, you may see rashes or lesions. The oropharynx needs to be observed for infections, exudate, or erythema. Assess for lymphadenopathy. Assess joints and bones for tenderness and swelling. You may need to do a rectal exam and do guaiac test. And for adolescent females, may require a pelvic exam. Clinical findings are you're going to need to have a CBC with a diff, a SED rate, a CRP, a procalcitonin, blood cultures, UAN culture, TB skin test, chest x-rays as needed, chemistries, a heterophile antibody and an ANA in older kids, possibly a bone marrow biopsy, and echocardiogram. Differential diagnoses include infectious diseases, collagen vascular diseases, malignancies, drug fevers, nosocomial infections, HV associated illnesses, so herpes simplex viruses, endocrine diseases, and of course, we need to also include in there Munchausen syndrome by proxy. Lastly, management is consultation with an infectious disease specialist, and they may require frequent visits to monitor. And without a known cause, empiric antibiotics are not used until there's some more definitive information to lead to antibiotics. That is the end of it, and I appreciate your patience, and this is going to end part 5 of this chapter.